Welcome to It's a Woman's World, a show which discusses any and all topics under the sun from a woman's point of view. Hosted by Alli Naithani and co-hosted by Uma Janga and Dr. Susan Strauss.
Welcome to the show. We've got another exciting show for you today, and let's get started by introducing my co-host. Susan Strauss is with us. Hey, Susan.
Hey, Alli. Thanks for having me here as your co-host. I'm excited about it.
Always a joy to be with you.
Thank you
for
much.
being here. Well, we're going to start off the show today. We're going to be talking about genetic counseling. So let's get started by introducing our first guest. Her name is Shari Baldinger. She is a manager of genetic counseling services on the oncology service line from Alli Health. Welcome to the show.
Thank you. It's glad to be here.
I first met Shari when my sister was diagnosed with breast cancer, and I was writing a book chapter on breast cancer, and interviewed Shari and learned a ton. That's why I thought she'd be such a good guest for our show. Shari, can you tell us what is genetic counseling?
Yeah. Well, genetic counseling is different depending on why someone seeks it. But overall, genetic counseling is a service provided by a specially trained healthcare provider, a genetic counselor, who's really trained to help communicate to individuals and families concerns about disorders or problems that might be inherited and how best to understand those, to manage those concerns and understand the significance for them and their families, as well as how to deal with those risks. And to make decisions that are appropriate for the individual. So that may have something different with respect to reproductive concerns or cardiac genetics or cancer genetics. In terms of cancer genetics, which is my current emphasis and passion, is we try to help people understand perhaps why they got cancer. If we know why they got cancer, if it happens to be due to an inherited reason, we can better impact their health and well-being as they go forward. They may be at higher risks for other cancers. There may be, because of why they got it, there may be certain therapies that they may benefit from that they otherwise may not have known it. And it may help their families better understand, gee, what's my risk? What should I be doing to deal with these risks?
Okay.
So it's a communication process to help people deal with problems, or in this case illnesses like cancer, that are in their family.
And can you give us an idea about some of the ranges of diseases that you can examine because of genetic predisposition? For example, you mentioned cancer, but what are some of the other diseases?
Well, again, genetics plays a role in almost all illness, perhaps except trauma. In terms of that, it just plays. The magnitude of risk might be different. So let's look at cancer, for instance. Cancer. We tell patients that maybe 5 to 10% of all cancer may be due to a major genetic risk. That doesn't mean that in the other 90% genes don't play any role. They certainly do, but perhaps less significantly. The likelihood that a strictly environmental cause of cancer is also fairly low, something like radiation to the chest. If I was a young woman and had Hodgkin's lymphoma and I got treatment radiation to my breast area, as a young woman, I would have a substantial risk for breast cancer going forward. Thyroid cancer in Chernobyl, leukemias after Hiroshima. But that does, and so environment and genes often have a complex interaction. So I can't really think of any disorder, frankly, even an infectious disorder. Why do two people get exposed to the same bug and someone gets sick and someone not? It probably has something to do with their genetic makeup. So there, yet one would not think of influenza or HIV as a genetic disease, but genes probably play a role there too.
So Shari, from the emotional perspective, right? Because when you're diagnosed with cancer, that must be very earth-shaking and traumatic in itself. But when people are looking for the answers, is some of that emotionally help them? Like, so for example, I could think of people might say, well, I didn't have any cancer history in my family, but I got it. And
Why did
so
it happen?
Can you tell us, like, from an emotional perspective, what does this, how does it help people cope?
It's a double-edged sword. The information is powerful but it's also empowering. And just as a little background, when I talk about a major genetic risk, I sometimes use the analogy that if you think of cancer as, let's say, a 16-ounce glass of water, for any woman to get breast cancer, or anybody to get any cancer, you have to fill that glass full of risk factors until there's enough that it spills over the top.
Okay.
And the reality is, if we know what filled your glass, we can be more proactive in your health than reactive. If I know what caused your cancer, then I could perhaps determine who in your family shares those risks. In about 5 or 10% of people who get breast cancer, they're conceived with a change in a gene that literally may put 14 ounces in that glass. It's not enough to cause cancer, but as a single thing, nothing puts more water in the glass, compared to, say, hormone replacement therapy that 4 or 5 or 10 years might put an ounce or so in that glass.
Okay.
So how does it impact? Well, number one, finding out that you might face that kind of risk if you haven't had cancer can be scary. But if in turn, if we give you that information, but then also say, here's what you can do about it, that you don't have to be the victim of this information. It can empower you to perhaps take water out of that glass or prevent putting additional water in. That's the empowering piece.
Okay.
I have met women who have been thrilled to know this is why it happened, because they may have falsely believed they did something or somebody else did something. Or they may have a lot of cancer in their family. And if they do a genetic test and it's normal, they're actually disappointed because they wanted to know what was going on.
Right, right.
And I think that's one of the biggest misunderstandings, especially with breast cancer.
Right.
There are 2 genes that are very well known now, called BRCA1 or BRCA2, which basically stands for breast cancer 1, breast cancer 2. I often have people coming in saying, I want the breast cancer gene test. Well, I wish there were the breast cancer gene. Mutations in those 2 genes probably account for less than half of heritable breast cancer. So when people get that test and it's normal, it's not bad news, but it's still no news. I still don't know what filled their glass, and I cannot tell them it was not another gene.
Right, right. But isn't some of this, though, that, because I also have heard people say, well, I tried to live a healthy life, I exercised every day, I ate right, but I still got this. Right.
So this could be a reason why. It's not the only reason why.
Yeah.
Probably, I've read literature from suggesting that maybe 38% of all breast cancer might be preventable with lifestyle and diet and exercise, environmental manipulation in the general population.
Okay.
I'm not sure. That's not my expertise, but people who have a substantial inherited risk, people who start off with a lot of glass in their water in their glass, their lifestyle can impact that, but they have a bigger road a tougher road to travel, because they may not be able to intervene in what is already a substantial risk factor that they've inherited.
Could you say something regarding the whole idea that all cancer is genetic, but compare that to the fact that not all cancer is inherited?
Yes.
I think people get confused with those 2 terms and conflate them.
Sure. When we say all cancer is genetic, it means that all cancer, whether it's skin cancer or lung cancer, breast cancer, colon cancer, if you took the cells of that tumor and evaluated the genetic makeup of those cells, there would be a substantial number of mutations and changes and damages in genes that may control how cells divide, act like brakes on the cells, like brakes on your car, genes that might keep your DNA intact, so DNA repair enzymes might be mutated. So there's a lot of damage in these cancers. That's why they're cancers. They no longer play by the rules. These are cells that can rapidly replicate and not stop when they bump into other cells. They're cells that can acquire other mutations rather quickly, perhaps to make them to better respond, to avoid the harmful effects of chemotherapy, to get resistance. So that's why sometimes people are treated and their cells, cancer cells, may come back because there are additional mutations that make these resistant to chemotherapies. But those mutations were acquired. They weren't inherited for the most part. If you looked at normal tissue, if you took a blood sample from these people and looked at the same genes, they would be normal.
So what causes these mutations?
They can be due to exposures. They can be due to random chances. Every time a cell divides, your body is copying 3 billion nucleotides, 3 billion letters, and sometimes random errors occur. And we have repair mechanisms, but sometimes random errors can occur and be maintained. Aging, just through lifetime, makes you more vulnerable to accumulating mutations. And then there are certain people's genetic makeup that may make them more vulnerable to accumulating mutations.
So fascinating.
Isn't it amazing?
But to contrast that, when someone inherits a mutation, I would find that genetic change in every tissue of the body. It's in healthy tissue. It was there at conception, so it's in every cell. Whereas most of the genetic damage in tumors are limited to the tumors.
Okay.
And there is a big trend now, there's the Cancer Genome Atlas that is
Yes.
intended at looking at the genetic changes in tumors, because if we can figure out what's wrong with those tumors, physicians and researchers can do a better job of targeting therapies to uniquely kill those cancers. Cancer is not one disease. As we spoke, breast cancer is at least 100 different diseases, and you don't
didn't
treat them
know
all
that.
the same.
Yeah.
My goodness.
I just read they were saying the same thing about colon cancer too. That
It's true of any tumor.
any.
There's a lot of diversity, and if you can better target what's wrong with a person's cancer, you can better treat it. But that's not typically something a genetic counselor would discuss, because those typically are not inherited changes.
Now, when I came in to see one of your colleagues to see about my own breast cancer risk as a result of my sister and others in the family, she used some tests to determine what my risk is. Could you just talk about that? I think they were statistical tests, weren't they?
Well, they were just models. There's a
Models.
variety. There's a variety of validated and models developed to help assess a woman's breast cancer risk based on her personal and family history.
Okay.
And that's important. There's a lot of models out there. There's one called the Gale model, which a lot of physicians use. It is a validated model. It was that model that was used to recruit women into the NSABP P1 tamoxifen prevention trial.
Oh, sure.
It was healthy women. They recruited over 13,000 women based on that model and divided them into two groups. One took tamoxifen, one didn't, and that was the one that showed that tamoxifen could decrease the chance of getting a certain type of cancer in women. And so a lot of people use that model. That model asks things like when you got your first menses, did you ever have a breast biopsy, were there any abnormalities? But from a genetics perspective, it only asks, does your mom or sister have breast cancer? And so if I had a dad who had 3 sisters with breast cancer, that model wouldn't incorporate that information, and it would do a woefully poor job at estimating my risk.
Because in that case, it's important to pull from the paternal as well as the maternal.
Yeah.
But I think sometimes people think breast cancer is maternal.
No,
only.
right?
No, it's not.
Yeah.
Equal.
Okay,
Equal.
it's equal.
It's equal.
Okay.
Dad's history is just as important as mom's.
Okay.
It also doesn't ask age of onset, so it would give as much weight to a mom at 80 as a sister at 30. So she would not have used the Gale model, likely, to really give you an idea of your breast cancer risk. You'd want to choose a model that allowed you to use first and second degree relatives, perhaps, and when they got it, so that it would take into account somebody who was young, or it would take into account if I had an aunt. If you had high breast density, you'd want to choose a model that incorporated that. Having very dense glandular breast tissue is a substantial risk for breast cancer, and some of that's under genetic control.
I know we're running out of time, but I have one quick question. Can you just make some comment about, does insurance cover genetic counseling?
Yeah, good question.
Typically, yes. In fact, more and more insurers are now requesting genetic counseling before a person seeks a genetic test. One common myth is that genetic counseling is equivalent to genetic testing. Genetic counseling does provide risk assessment, a management program that fits your risk, so you know what to go back to your doctor with and say, this is what's recommended based on my risk level. And if a genetic test is indicated, they will help be sure the right person in the family gets the test and that the results are properly interpreted. So they help you make an informed decision. Whether that decision is yes, I'll do the test, or no, I won't, at least it will be an informed decision.
Well, Shari, unfortunately, our time has come to an end.
I
But
went quickly, like you
want
said.
to say thank you so much for coming out and talking to us about this important subject. And
My pleasure.
Have to have you come on again, because I think we have more conversation.
Yeah, there's a lot more. We kind of got a little
so
sidetracked
much,
there.
and so thank you very much. It was just enlightening. I appreciate it.
Yeah.
Well, it's nice to be here. Thank you.
All right. Well, Susan, up next, we are going to talk to Carolyn Moors, who's an organizational coach. So stay with us as we speak with Carolyn Moors. Well, we'd like to begin the second half of the show and introduce our next guest. Her name is Carolyn Moors. Welcome to the show, Carolyn.
Thank you so much, Alli.
So, as I understand, you are an organizational coach, a mentor, a trainer, a speaker, a blogger, a psychologist, and you're also the founder of Hard Talk Biz Coaching.
That's correct.
Excellent.
That's correct.
Quite a bit
I
to
would
be proud of.
say, and
Sounds like I'm busy.
It does.
But before we get into the wonderful conversation, we want to hear how you pronounce your name.
Oh, thank you. That's very kind of you. Generally, when Americans ask me how to pronounce my name, I say pronounce it or try to pronounce it the French way, which is Carolien.
Carolyn.
And that's exactly how we pronounce it in the Netherlands. So, yes, it's Carolien.
Beautiful, beautiful.
Yeah,
I didn't
it's
want to
so
miss
pretty.
that. I think
It is
it's
pretty.
just beautiful.
Thank
so thank
you.
you for doing that.
Oh, yes, absolutely.
And you mentioned the Netherlands, and that is your home country, and you just returned from there last night, and look at her, no jet lag apparent.
Just last night? You
Yeah,
came out? Oh, my
We
goodness.
landed at 7:30 last
Yes.
night.
My
Yes.
goodness.
So tell us, I know you've got family there and friends, but tell
right.
us a little bit about the trip.
Oh, it was just wonderful. We spent 9 days, the children and I. My husband stayed here to work, but it was beautiful. The main objective of the trip was to visit family and friends, but mostly family. I have very aging parents. They are 82 and 86. And it was just wonderful to be able to see them still in their own home, living
Good,
independently. So, but we also traveled around a little, and some of the family members we had asked to meet close to my parents' home, which is in the south of the Netherlands, and it's close to Germany and Belgium. And there was beautiful hills, ancient cities, old castles and palaces. So we tried to also be a little bit of a tourist in our home country, especially for the children, because they
Yes.
only get to see it once a year.
Well, I've been to the Netherlands, and I loved visiting. I'd like to go back. And with your European background, you then are able to do some of your coaching and your mentoring and your training on an international level as well. Tell us about that, and what differences might you see between dealing with U.S. culture, organizational cultures, and some of the European cultures?
Right, right. I love that question because I love different cultures and learning from and through different cultures. When I started in this business, in this field 23 years ago, my very first project was for a German, a vacation resort. And I had to write the whole training and coaching materials in German, as well as perform all the training and coaching in the same language, of course. And that was a huge challenge. Even though I speak German, it's not just the language, right? And you mentioned very correctly that there are subtle and less subtle differences between different cultures. So one example between the German and the Dutch culture is that Germans tend to be more hierarchical, which is a difficult word for me to pronounce, but I hope I did it correctly.
You did beautifully.
You did.
So they appreciate the certain forms in language that are more, formal, probably. Whereas in the Netherlands, we tend to be very informal, including with people superior to us, including with bosses. So that is something I had to keep in mind. And there were many different aspects during the training and the coaching that I was very aware of, conscious of. And, that takes energy and time, but it's also a nice challenge. I appreciate trying to really understand and submerge in a different culture.
Was it difficult then for you when you came to the U.S. after being used to doing business in European cultures to come into the U.S. culture?
Not necessarily. I spent a year in the UK, which was I think it was my 6th and last year at university. I went to the UK, and there are quite a few similarities between the English and the American culture. Also, I studied and worked in the UK and had some English clients as well, English corporations that were headquartered or located in the Netherlands. as well as American companies that I worked for in the Netherlands. And they were smaller companies. They had a small office there. So I was used to some of the differences. And something you may not know, we have spent a previous period in the U.S. from 94 to 2000. So this is actually our second time in the U.S.
Okay.
So that was the main big jump for me when we moved here in 94 to Florida.
Okay.
And I have to say that there are quite a few differences between the different states,
Yes.
as I'm sure you
yeah,
know even better.
Absolutely.
That's right.
Yes. So we started in Florida, and then we moved to Minnesota. And I think not just weather-wise, but in culture,
Yes.
it's
different.
it's a
It
leap.
is. It
Yes.
is. It is
Yes.
different.
Well, Carolyn, what do you find inspiring for yourself to do this type of work as you
Right.
work with people and
Right.
leadership, as you talk about?
Right.
Tell us about that.
Right. Well, I always feel very honored to be able to work with people because I don't think it gets any better, right? What inspires me most is to see people gain insights into their long-term and sometimes even lifelong non-effective habits, unproductive thinking patterns, sometimes mistaken assumptions, as well as typical habits, behavioral habits that they are not aware of or not totally aware of, and especially the effect that their behavior has on others. It's very inspiring for me to play a small but essential role in that journey towards greater insights. But what inspires me most probably is to see people's courage and resilience and their effectiveness increase.
I would just like to add that Carolyn's got 3 master's degrees.
Oh, 3.
3 of them. And 2 are in psych, clinical psych and
Industrial psychology,
Okay.
correct, yes. I didn't know what to choose, and some advisor at university said, well, maybe you should do both. 1 year, one during the day, one at night, and then choose. But I never chose because I loved both of them.
That's very impressive.
Yeah, very.
My
Thank
goodness.
you.
Well, then, one thing as I was thinking about our discussion today was when we go for goals or as we live this wonderful life, we have problems that come up, but we have just the day-to-day existence, right?
Right.
How do we achieve to get to the next thing that we want to? There's something that I read on your website where you talk about excuses. And
I love that topic.
I really like how you phrase this, and just if I may read just real
Oh,
quickly.
absolutely.
One of the things you said was we make all kinds of excuses, sometimes very sophisticated ones. I liked that. I thought that's very true. Excuses that even we believe in. We make excuses for not achieving our goals and for not making the changes we know we should or we say we want.
Right.
I thought that was a very poignant part because I think excuses allow us to kind of wallow in that world. So tell us more about excuses and how do you help people achieve goals and get over the excuses?
Right. Well, that ties into my provocative approach because I often have to be brutally honest with people up to a provocative point where I give back to them the reasoning and the language and the words that they choose. And the language that you choose tells me a lot about your assumptions and about your thinking patterns. And I'm not always right, but I tell them this is what I hear, this is what it makes me think of, this
Okay.
is what I could conclude from what how you think and how you talk. And I think it's not effective or it might even be destructive. And this originates partly in cognitive psychology, which is the psychology of thinking and thinking patterns and assumptions. Also, it originates in my clinical background where I obviously studied disorders and addictions. And if you talk about victim behavior and about excuses, if you think about people with addictions and people not necessarily with psychiatric disorders, that's a different category, but with all kinds of concerns and challenges that they are facing, generally you and I would like to know and would like to think and believe that we didn't cause it, right? Because that makes us feel better. However, even if life dishes you very difficult situations or circumstances, maybe your upbringing wasn't the most ideal one, or there were major life events that you might even call traumatic, I can be very understanding of those circumstances, but still, this is where you are today.
Okay.
And if you want tomorrow to be different than yesterday, you will have to change something, right?
Yes.
And we can remain stuck in how bad our upbringing was or how horrible the traumatic event was. But if we don't look at our insights and skills and literal habits and behaviors that we use now and tomorrow, then nothing's going to change. So
We hear you talk about working with people on an individual capacity, but do you go into organizations then and work with, say, teams to enhance team dynamics and their ability to work together and maybe help facilitate some conflict resolution? Maybe you could just address a little bit what you do with groups.
Right. And that's exactly what I do. I enjoy... When people tell me at networking events, well, what is it that you enjoy or that gives you energy, I tell them, well, it might not sound very kind or friendly, but I love dysfunctional teams.
Oh, wow.
Because there is real work to be done, right? Yeah. I can work with a team to help them perform just a little bit better and communicate a little bit better, and I do that too. But if there are huge issues that keep teams from performing the way they could and the way they should, that's where I love to come in. So yes, I do work on conflict resolution. I do work on literal collaboration. We do a lot of communication work, but also choosing and, well, I should first say choosing the right people in your team as well as using them up to their best capabilities. Because you might be excellent at leading a team, but if you are put in a position where you are just a team member without any organizing or leading roles, then we might not be using you up to your possibilities, right?
Effective way, I suppose.
Right.
You know, one of the places that I worked, we did the Myers-Briggs type inventory throughout just about the whole organization, and we used that in creating teams to make sure that we had people that represented all of those various factions of MBTI, and it was phenomenal.
Right. Oh, it provides great insights.
It does.
Yes. I do not administer any of these tests. I'm familiar with them. I know them. I know what they test. And I work with other people in the field who do administer the tests, and they give great insights. Also, I always tell people a test is never the end goal. It's one instrument to start a conversation at a deeper level.
Yeah,
so
I agree.
appreciate the information, and then let's talk.
Yes.
How do you evaluate and interpret it, and how do other people evaluate it? So it's a starting point for me.
Well, unfortunately, our time has come to an end, but I wanted to ask you if someone wanted more information, do you have a website that they could go to? Or
I have a blog, and that's where you received your information from.
Yes, tell us
absolutely.
that, at that address.
Okay, it's obviously www.caro, and then my last name, Moors, blogspot.com.
Okay. And we thank you for being with us today, and we hope you join us next time on It's a Woman's World.